everyone. My name is Dr. Mimi. I'm a neurologist at Maitama District Hospital, and I'll be taking you on stroke. I'm going to follow this outline. Okay, so stroke is a clinical syndrome consisting of rapidly developing clinical signs of focal or global in case of coma, disturbance of the cerebral function for more than 24 hours or leading to death with no apparent cause other than a vascular origin. I just want you to pay attention to the vascular. That is vascular origin, that's number one. This is a very old definition, WHO 1974-75. However, there's a newer definition that captures the fact that it can occur in the brain, spinal cord, or retinal cell death. Very important, because when you're someone who just has impaired vision, just one on one eye, for instance, it could be a stroke. That's what we're trying to draw your attention to. It's neuropathological, neuroimaging, and or clinical evidence of permanent injury. All right. All right, TIA. Now, this is where I want you to pay attention to, because people keep mixing this up, all right? So, stroke symptoms and signs that resolve within 24 hours. Now, it can occur in the brain, spinal cord, or retinal ischemia, without evidence of tissue infarction. And this evidence of tissue infarction is brain MRI, not CT scan. So if you have a patient who presents to you and you say initially had symptoms that have resolved within 24 hours, and you do a brain MRI, brain CT scan that is normal, you haven't exactly excluded TIA if you have not done a brain MRI. I hope you got that. Okay, I'm going to skip this. Okay, so for epidemiology, I just want you to know that up to 80% of strokes are ischemic. So stroke is not only ischemic strokes, but 80% of strokes are ischemic, and most of the risk factors for stroke are preventable, up to 80% as well. So for classification, this slide is just to let you know again that stroke is not just only ischemic stroke, even though it is the commonest, and it is based on the vascular system, either, sorry, I'm trying to use the pointer, but I guess I can't use it on an LED screen. So arterial or venous, pathological, whether it's infarct or an hemorrhage, and then the site, that's the location. When I'm talking about the clinical features, we'll take a deeper dive into the site of the lesion, so I'll just skip that. Okay, but for hemorrhage, it can either be in the brain, parenchyma, or subarachnoid. Then clinical classification, I'm going to be repeating this, so I'll just leave that out. So just to know that, for you to know that stroke is actually broad, and it's not just ischemic stroke. So the popular one that you all know is, when you're asked to classify stroke, would be ischemic stroke, hemorrhagic, or subarachnoid. We like to separate some subarachnoid from hemorrhagic because it's a different entity and the treatment is actually different, and the symptoms are actually classical, so it's better to separate them. Okay, so sub-stroke, ischemic stroke subclassification. This is very important because when you're profiling your patient, because one of the things we do when we see a patient who has had a stroke is that we profile the patient. And it has to do with the location of the stroke or the etiology of that stroke, and that would inform our evaluation or investigation for that patient. So there is the trial ORG, TOAST for short, and it's what you already know, large artery disease, typically caused by atherosclerosis. The previous speaker spoke about that. Then cardioembolism. Then small artery occlusion. I'm sure by now, if you've been looking at a lot of brain CT scan, MRI, you've been seeing small vessel disease and things like that. Small artery occlusion, lacunae. Then stroke of other determined etiology. So it is not always a large vessel disease, cardioembolic or small. There are other like vasculopathies, for example. Then there are cryptic strokes of undefined origin. Then strokes, then Oxfordshire Community Stroke Project. This is another form of classification. It's somewhere in my slides, so I wouldn't talk about it so much. So risk factors. So there are non-modifiable risk factors and there are modifiable risk factors. Now, this is important. For non-modifiable risk factors, as you already know, there are things that we can't do much about, okay? Increasing age, gender, it's commoner in male than in females, and a female past 55 years of age, race, African descent, for example, family history of stroke, a previous vascular event such as a stroke, MI, peripheral artery disease, and hypercoagulable states, and some hereditary conditions. Then for the modifiable risk factors, so we have here hypertension, someone called it the big four, hypertension, diabetes, hyperlipidemia, and hyperlipidemia. Then there are other things like cigarette smoking, excessive alcohol intake, physical inactivity, and heart diseases such as atrial fibrillation and heart failure. Then other things as well. Then for the pathogenesis, okay, all right. So for the pathogenesis of ischemic stroke, what you need to pay attention to are these three colors. So we have insets is the red color, that is the core. So that is where the infarct has occurred. And then around it you have the penumbrum, that's the orange area or the amber, then the green, benign oligemia. So the orange and the green areas are, they are salvageable. So that informs the intervention that happens when a patient presents as quickly within the window period of up to 4 to 5 hours after the last well-known time. Okay, so clinical features, all right. So it either occurs in a sudden onset, stepwise progression of symptoms and signs over hours or even days, okay, or focal signs relate to distribution of the affected artery, but collateral supplies may cause, okay, supplies may cause variation in presentation. Okay, so based on the arterial supply, I'm going to skip this. So I'm going to go on to this slide. So occlusions of the arterial cerebral artery primarily affect the frontal lobe, okay? And that's the area highlighted in yellow. So there will be disinhibition and speech preservation, and then there can be primitive reflexes that are usually predominant at birth and that are lost, but they now resurface, like grasping, suckling reflexes. And then, of course, altered mental status, impaired judgment, collateral weakness, which you already know. But usually, if the frontal lobe is affected, it's greater in the legs than the arms. The code for that is put your left foot forward. That means that it's most likely in frontal lobe. Then contralateral cortical sensory deficits as well. Just to note that sometimes it's not always weakness, sometimes it's just abnormal sensation, burning sensation on one side. So it's not always a spondylosis. Sometimes it can actually be a stroke. Okay, so for middle cerebral artery stroke, then also contralateral hemiparesis, contralateral hyperesthesia, ipsilateral hemianopsia, and gaze preference towards the side of the lesion, then agnosia, repetitive. All right, so I'm going to skip that. Then posterior, so the major areas are the anterior, and then the posterior cerebral artery stroke. So for the posterior ones, what is typical are the 4 Ds: dizziness, diplopia, and dysphagia, and then dysarthria, very, very common. And then sometimes cortical blindness, visual agnosia, altered mental status, and then impaired memory. So these are more signs of posterior cerebral artery stroke. So, diagnosis. 10 minutes more. Okay, sorry. I have to really fly. So for diagnosis, remember that stroke, please remember that stroke is a clinical diagnosis. Sometimes people just get away with CT scan right away. You can make a diagnosis of a stroke based on, is clinically, based on from the history and physical exam. Please take note of the onset of the focal neurological deficit. How did it start? Very important question. When was the patient's last well-known time? Okay, he went to bed at 10 p.m. That was the last time we saw him. By the time he woke up to pee at 4 a.m., he couldn't move. That was, so it's already past, 4 hours or so to say. So that is a very important history which you must get from the patient. Okay, the last well-known time. Then the next thing you need to pick out from the history is, are the possible risk factors, the ones we went through, a previous family history of stroke and all of that, or the person has had a stroke before and things like that. And then hypertension, diabetes, sedentary lifestyle, and the rest. You have to capture all of these things. Then possible complications that may have occurred. So in this setting, sometimes patients arrive 1 week after the stroke. So you should take a history of possible, complications. Okay, depression, for example, can't be there already, and then DVT, of course. Then exclude other causes, and then we go to the physical examination to elicit for the focal neurological deficit. So here are CT scans demonstrating, the first one shows an ischemic stroke. Okay, in the left frontal parietal and occipital lobe. That's the first one to your left. So differential diagnosis, when patients have either hypo or hyperglycemia, it can present as a stroke, cerebral tumors, or metastatic tumors, cerebral tumors as well. Then extradural or subdural hematoma, just especially when you're dealing with an elderly person who has been dancing, for example. That excessive movement can lead to a subdural hematoma and can present with one-sided body weakness. It may not be a stroke, but by the time you do the CT scan, you now, bring that out. Then cerebral abscess, Todd's palsy. If someone has been having seizures, for example, they can have sustained one-sided body weakness. And then encephalitis. So complications, increase intracranial pressure, seizures, infection, that's bed sores or pneumonia, DVT, pulmonary embolism, SIDH, and depression. All right, so our management goals actually is to protect the orange and the green area, all right, so from necrosis. So attempt to reverse or limit the degree of brain dysfunction, rehabilitate the disabled patient, that's physiotherapy, occupational therapy, speech therapy, prevent and treat complications. That's very important, secondary prevention of stroke. And the idea is to optimize prevention of recurrent stroke. Okay, so the whole idea is within 60 minutes of presentation. So assuming a patient comes to any facility, maybe 1 hour, as soon as they notice the one-sided body weakness or facial weakness. Okay, so there's this acronym FAST that we usually do for sensitization. That's facial weakness, A, arm or leg weakness, S, speech impairment, and T is time is brain attack. So as soon as they arrive at the door, within 10 minutes, should be assessed, and within 15 minutes should have gotten some form of neurological expertise to actually think that, okay, this is a stroke, and within 25 minutes should have had a CT scan done, all right, and then 45 minutes interpretation, and then treatment 60 minutes. Now, I can see that some of you are laughing, but this has already been done with the help of probably cardio care. We have done like for 2 patients already, and it just has to do with forming a team. So you already know that someone has had a one-sided body weakness. How soon can this person see someone who has some form of neurology inclination and can assess for sure? And if that is done, Their phones, their diagnostic centers that work 24 hours, and because of technology, they can send the image to the radiologist and the neurologist that can see, and at the same time can evaluate and see if the patient counts for, qualifies, is eligible for thrombolysis, and it can be done. That's the message. So just like he said, ICU does not have to be a real ICU. It just means one patient to one nurse and one doctor. The same thing, thrombolysis can be done. The only other factor will be funds, okay? Because in essence, after the patient is leaving the CT room, the patient should be getting the thrombolysis already, and then move to an ICU facility, a facility where an ICU is present. So let me jump the stroke unit. So in management, I've summarized it like this. So there is the resuscitation, then reperfusion and perfusion. So reperfusion is where you do the thrombolysis if the patient qualifies. Otherwise, you move to perfusion. The perfusion is where you give enough intravenous fluids and you maintain the blood pressure at a certain level. You don't crash the blood pressure. Very important, because the brain cells need to be perfused. That orange and green area have to be sufficiently perfused.
So we should leave the blood pressure 230, 120. We should not bring down the blood pressure. We should leave it and tell the patient, sorry. Dr. Mimi said we should leave it like that.
Okay, so they are.
I mean, somebody is asking that question in their heart, Abby.
Yes. So if skip this.
So please, thrombolytic therapy. Somebody has a stroke. Please, if you don't have access to a specialist, please don't do so. Don't do it on your own, please. Because that ischemic stroke will easily turn bloody in front of you. So please don't do it on your own. Make sure you have guidance. Now you see some QR codes. You can join a WhatsApp group. You can ask any question. If you have a live patient and you need some guidance, you can reach out to us. We will give you some free advice. But you must first tell us what you want to do.
All right, thank you. Then, so if the patient presents within 48 hours, to reduce the risk of mortality and disability, you give 300 milligrams of aspirin start, and then 150 subsequently. But if it's past 48 hours, you just stick to the 75 milligrams. Then, okay, let's move. I'm going to move. So this is modified ranking score and any NIHSS score for scoring, assessing severity of stroke and the measure of disability. So perfusion, this is where you give normal saline, IV normal saline, 1 liter, 8 hourly to see to the perfusion of the brain, and permissive hypertension. So you calculate, so the easiest way to do it is if it's an ischemic stroke, if the blood pressure is greater than or equal to 220 or diastolic 120, then you give a parenteral antihypertensive. But if it's hemorrhagic and is greater than 180, 120, you do the same. You give, that's when you attempt to drop the blood pressure. And even as at that, you're not crashing it. The target is that you want to reduce it by 15 to 25%, as in that's the measure of drop by which you want it to drop in the first 24 hours, and it's not a massive, crash. So that's for blood pressure control. So typically we use labetalol. That's the common one we use.
What of hydralazine?
Oh, please don't use hydralazine. Please don't use hydralazine.
How many people use hydralazine? Don't raise your hand up, so I don't know.
All right. Okay. So, but there are some compelling indications where you, even with that, you have to give antihypertensive. For example, if the person has dissecting aortic aneurysm, ischemic MI, acute pulmonary edema, and so on, okay? But basically, we don't. So rehabilitation, please start neurorehabilitation almost immediately, as soon as possible. And of course, it's gradually, not so intensive at the beginning. Actually, the physiotherapists know what to do. But the idea is to start as early as possible. There's speech therapy. Then secondary prevention, very important. The goal is to optimize prevention of recurrent stroke by addressing the risk factors. So the whole idea is that you have the risk factors in your head and you're investigating along those lines and you're treating, because the cause of the stroke or the major risk factor of stroke in any one individual is not always the same. So even though the person is hypertensive, doctor, my blood pressure has been controlled, my sugar has been controlled, why did I have a stroke? Well, there are other things. That's why there are lifestyle measures. There's stress. The person is still smoking. The person is still eating, all the wrong things. Oh, the person has dyslipidemia. So you have to look at all of these things, or the person has atrial fibrillation. So that's why secondary prevention is very key. And something I should tell you about secondary prevention. Some people do not know that they have had a stroke until you have done the CT scan. I saw one yesterday. The man was very upset with me. Doctor, I said I have not had a stroke. I said, okay, calm down, sir. Now your CT scan shows that it is a chronic infarct. So it does not explain why you just had, as in your current symptoms. So you have had a one. So because you did a CT scan rather early, sometimes it doesn't always show the infarct. So now this is the second stroke. So we have it on so we're in our profiling this patient now. This patient has had 2 strokes. So we have to be double careful, extra careful with this patient. So that's why we do things like, because of time, I won't be able to go through large vessel, cardioembolic, and small vessel disease. But if it's atherosclerosis, that's a large vessel. So that's why we'll ask the person to do a carotid Doppler, for example. We won't be playing with all the risk factor that Dr. Salau talked about to really profile the patient and start the patient on statins. And if the patient is, and then we also do an echo, whether or not the patient, we must do an echo, and then we don't just do a routine ECG, we do a 24-hour ECG, just in case we pick any arrhythmias, we can pick any. Then please do not play with these lifestyle measures, because more and more I'm beginning to see very fit individuals who are not inactive and they have had a stroke. Why? Because they indulge in some of these things. They're still smoking, excessive alcohol, and sometimes they do not do regular, even after doing regular exercise, they sit for a long hour. So at this point, with the permission of the coordinator, please stand. Stand. You've been sitting for too long. So let me just break it down to you. You see, when we accuse people of smoking too much, right? The people who have been sitting too much, they are brothers. They are at par. It does the same. It's the same, about the same cardiovascular risk. So just stretch. Yes. So do that from time to time. It will help your cardiovascular health. All right? Can I finish up? You can stand while I'm doing it. I hope you don't mind. All right, you can sit.
You can sit down.
Thank you. So,
but if you want to
they go home, and then we don't see them until years later. Maybe they're coming with another stroke. So please and please, very, very important. So I'm going to skip this because there's no time. All right, so hemorrhagic stroke is similar, but the only other thing about hemorrhagic stroke is no, I'm going to skip it. This is too much. Okay, I'm just going to skip it. But typically, headaches, vomiting, neck stiffness, I beg your pardon, focal weakness, and altered sensorium are typical for. But don't bother trying to, say which one it is. After you have done the resuscitation, send for a brain CT scan, and we'll deal with it.
So we cannot manage stroke without a brain CT?
Yes, yes, we can't.
So what do we do for those that don't have access to brain CT?
Well, we can just do watchful waiting. That's all. And just control the blood pressure, address the risk factors. And if there's any, for example, if we don't have a CT scan, for example, and the blood pressure is already over 200, so it doesn't even matter whether it's ischemic or hemorrhagic, you have to control the blood pressure, for example. Do you understand? Okay. So that's what a bleed looks like, the one in the middle. All right. So subarachnoid hemorrhage. So for subarachnoid hemorrhage, usually the patient will complain of headaches, the worst headaches of his life. That may be the only symptom. The person may not have altered sensorium, may not have focal neurological weakness. In fact, someone called me, Dr. Mimi, please, my patient is in XYZ, they've done a CT scan, and she's still complaining of headaches. When they sent the profile, and I said, don't take your patient from that hospital. That they are doing the right thing. It's a subarachnoid hemorrhage, and it's usually the headaches that can be difficult to treat, but just be patient and the patient will be out of there. As long as they've done the CT scan and they are on the other medications, the patient will be fine. So typically what we do for them is we make sure that we control the blood pressure. Where do I have it? All these are scoring. Let me skip all of that. Let me get to where I summarized it. All right, so basically modified ranking score, that's disability, because it will help you mark the patient's progress. If the patient came to you and could not walk, but before, at some point in the course of management, the patient can now walk with assistance, at least celebrate some victory, as in that's progress. Do you understand? Then resuscitation, that's your ABC. And remember to do a swallowing evaluation, very important. Send the patient for CT scan. If it's hemorrhagic, you treat it, look at it. If it's reduced BP, if it's greater than 180/120 millimeters of mercury. Now, you may say, I'm not highlighting MAP. Yes, you can calculate the MAP and all of that. But you see, when the proverbial rubber meets the road and you need to take action, you just remember these figures. Before you remember the formula and start calculating, just take action. Then, and that's what's in the guideline anyway, but you can do that. There's no harm in doing that. And then if it's ischemic stroke, a candidate for thrombolysis, you go ahead. Not a candidate for thrombolysis, you take that route. But in all, antiplatelet therapy, and then secondary neurorehabilitation, secondary prevent complications, and that is it. So time is brain is a leading cause of disability, resuscitation, reperfusion versus perfusion, neurorehabilitation, and secondary prevention. It's a multidisciplinary approach. Thank you very much.
Please, a round of applause for Dr. Mimi. All right.
Okay, questions?
Yes, please. So please, any questions? Do we have questions? I have questions. Okay.
Questions?
Good afternoon, everyone, and thank you so much, Dr. Mimi, for this beautiful delivery this afternoon. My name is Dupe, and I have a question about stroke. About 2 months ago, my father had a stroke. When I was called, because I have a bit of knowledge of handling strokes, being an ACLS instructor, I rushed off to him. However, my timeline of getting to him was more than 4 hours. So let's say 6 hours after that stroke incident. I didn't get the news on time. Now, I passed that stroke for a TIA because he had hemiplegia, so weakness on the right side. But each time I asked him to hold my hand, and then he happened to be a doctor too, and he's very active. So I'm looking at all those criteria and saying he's not, and he doesn't have any of these risk factors. But asked him to hold my hand, and the power in his hand was very loud. I could put it as a 5/5. So we took him for a CT to find that he had a clot in the hypothalamus. So a thalamic stroke, right? That's what it was called. Now, is that a stroke?
Stroke now.
Look, forgive my question. Forgive my question, because that's the first time I got to see that. I've been waiting to say, okay, did we do well? Did we not do well? Now, after the CT scan, we're able to manage him on clopidogrel, vasopressin. His cholesterol was slightly elevated, but I'm asking. Sorry that I'm asking, but I'm asking, in what classifications then will that be? So ischemic, right? Is that, should we? He didn't have any risk factors. He's active. He's a surgeon. He's active. His BMI is fair. So I'm looking for what could have been the cause of that. Yes.
All right. Thank you for your question. Sorry
She's
about your
asking whether
dad.
it is village people.
Okay. Father and daughter are doctors. I don't think they're thinking village people, right? Okay. So sorry about your dad. So there are other things to look out for the in the risk factor. So it's a stroke and it's an infarct. So the thalamic, and and if we do a more extensive evaluation, maybe like sensation, maybe we'll pick one or two things, especially the thalamic. In fact, the patient I was trying to describe also, it was a thalamic infarct as well. I said, no, doctor, I didn't feel it. I'm fine. I mean, I would have known if I had a stroke. And I said, you don't always know. Anyway, so it's a stroke, it's an infarct. Then look at other things. How about his sleep? Does he get up to 7 hours of nighttime sleep? He's a surgeon. Does he get up to that? So even after we've done, so you may also need to do 24-hour Holter to pick any, arrhythmias. Do you understand? You also need to do a carotid Doppler. Do you understand? Maybe there are some plaques somewhere and all that has got unstable. So there are a lot of more investigations that can be done. Sometimes it's even just stress, right? At the peak of stress, and then the person just has a stroke. So and sometimes we don't always know. So sometimes we truly do not know. Okay? Thank you.
Thank you very much. One more question, please.
So the important thing is that all patients with stroke should have a CT scan. I think we've made that point very clear. Number two is that all patients with stroke should be properly investigated. Have the full range of investigations, from carotid Dopplers to uric acid to homocysteine levels sometimes, to echoes, to Holter ECG. So sometimes they have an arrhythmia. I saw a man yesterday, he has an atrial fibrillation, it comes up, by the time he comes to clinic, it's all over. Luckily, the last time he had one, he went to a nearby clinic, they did an ECG. So we had that picture of the atrial fibrillation that happened. Then we put him on a Holter. So sometimes you need to actually check, because you know what is happening, and treat appropriately. So please, there is no such thing as, thank you. Before the next question, some people, including health workers, say the patient had partial stroke. That they had partial stroke. Is there anything like partial stroke?
Please, there's no such thing as a partial stroke. If the person has had a stroke, it's a stroke. There's no because it undermines the severity of that stroke, even no matter how small it is, because that person is at risk of having another one. So you just undermine it when you say a partial stroke. No. So there's no such thing. Okay, a stroke is a stroke.
All right, next question.
Good afternoon, and thank you for the presentation. My name is Ijoke Otiba, and I'm a physiotherapist. And the question I have is this. At what point should you, after stabilizing the patient, at what point should a patient be referred for physiotherapy, or at what point should physiotherapists be involved in the management of this patient, knowing fully well that from your presentation, early referral or early involvement of physio is important? And then secondly, my question is this, adding to the first one, how late is too late? Then secondly, looking online currently, there are a lot of medications that, you know, people are manufacturing and pushing out, and it seems nobody's saying anything about, I mean, people are not really saying much about this. And, you know, the problem is we have our parents at home, we have friends, relatives and all that, and they see those things and some of them believe it. How do we actually go about debunking these things since they are really going viral? People are running ads to sell all sorts of medications that they claim will cure stroke, and then a lot of people are being scammed by that. Thank you very much.
All right, thank you very much for your question. So just like you said, I projected in my slides, in my presentation, as soon as a patient has a stroke, the patient should benefit from physical therapy. ASAP, that as soon as one is available. However, the intensity varies, okay, because we know that exercise, especially exercise, can increase blood pressure. You get me? But that, especially when the patient has a focal neurological deficit, the patient needs a physical therapy. Now, this is important, especially when it is a hemorrhagic stroke, for example, that we cannot give antiplatelets until maybe weeks after, because there's a lot of back and forth on when we can give, you know, anticoagulants. So the best thing we can do is to put, you know, the compressive stockings, or to get the patient to have physiotherapy, so as soon as possible. Then when it's too late? Well, I would say it's never too late. It's just that the person may have, you know, had a contracture by the time, you know, they start seeing a physiotherapist, and that can be very difficult. I've seen patients who have had a stroke, and because they were tired, honestly, the patients can get tired. Sometimes it's not always money, and they're just tired because sometimes it's a painful experience, and then now the hand is now fixed. You know, I mean, even dressing and moving can now become difficult, but at least if it's, you know, it's easier. So physiotherapy, I would say, is never too late, but as soon as possible is best. But of course, the physiotherapists know that they start gradually and, you know, upward. Okay, debunking those drugs. So, like every other disease, there's always a silver bullet. This drug cures everything. It's everywhere in the domain. So it's your responsibility, you know, to become informed. That's why you're here. And so we work with the guidelines. And even with the guidelines, there are some what we call off-label, based on expert, you know, opinion. There's some drugs that we use, especially in the domain of stroke, that has to do with neuro rehabilitation, you know, and things like that. So there's some like citicoline that we use, okay, but it's not yet in the guidelines. But we have seen improvements with our patients. So we try that, we discuss them at our conferences. But aside that, you know, all this vitamin E and some other funny things that you see in the market, you know, so it's up to you to, in fact, when they come to me, I don't really spend time talking about that. I just tell them, well, that's up to you, you know, because I don't think that we are still learning. We're still trying to get information. What if they even try one of these things and it actually works? Okay, that's fine. We'll look at it. But categorically, it's not in the guideline. So it's up to you to protect and get informed and protect your own. Thank you.